Hey, good evening, everyone. Great to see everyone for this live from Cleveland Clinic. We have a very nice program tonight for more than an hour. We're actually going to talk about state-of-the-art management of perianal Crohn's disease, obviously a very challenging problem, and we have great experts to talk about that. And we have more than 600 healthcare providers registered from more than 91 countries around the world, which is really very exciting. For that reason, also, we thank our moderator or sponsors. Next slide, please. Cook Medical, Johnson & Johnson, and Medtronic. Next slide. So the panel tonight is Dr. Cohen and myself to moderate this session, and we have a few great talkers. We have Dr. Holubar, which I will present more in detail in a second. We have Dr. Eric Canters, Dr. Jessica Philpott, and two of our brilliant fellows, Dr. Christopher Preen and Sophia Trusilio. And so, next slide. We'll start with the first presenter, Dr. Stefan Holubar, who is in our Department of Colorectal Surgery. He's Director of Research and a Clinical Professor of Surgery, and he's going to talk about the updated classification and definition of healing in perianal Crohn's disease. Stefan, please go ahead.
Thank you so much, Anthony, and happy and healthy 2026 to everybody. And Anthony, can you just confirm you can see my slides?
Yes, I can see them.
Okay, great. So this is the outline. It's only a 10-minute talk, so hold on to your seats, and we're going to talk in depth about the classification and the implications of the classification for perianal Crohn's disease, focusing on the top class classification, which stands for treatment optimization and classification. This is the overall classification that was published by Geldof et al. In Lancet GastroHep in 2022. And we're going to go through almost all of these tonight. We're going to jump right into start talking about class 2, which is probably the most common one that we all see. It's patients who have a chronic symptomatic fistulae, and we're going to focus a little bit about repair, and Dr. Canters is going to talk more about that later. But overall, the first step when surgically dealing with perianal Crohn's disease is to control the sepsis, and we're going to talk more about the concept of surgical rationalization. Then after you kind of control the sepsis, we're talking about control of the inflammation. That's where the treatment optimization comes in. And Dr. Philpott's going to talk to us more about the advanced therapies in 2026. And then once those two steps are taken, the stage is set for the possibility of repair. And so a little bit more detail about this concept of surgical rationalization. It's really about ceton saturation and then stage simplification. And you can see the photograph. There's lots of drains and cetons, mushroom catheter to really drain all the sepsis. So then you can move on. And so it really starts with each and every tract and branch gets drained. So you get maximal control of the sepsis. Then you optimize your medical therapy and you perform serial exams under anesthesia over the course of months, trying to remove 1 or 2 cetons at a time, sometimes with subcutaneous fistulotomies, which doesn't take any sphincter. And the hope is that with surgical rationalization, ultimately you're left with a single, often transenteric fistula tract that then you can go for repair. I'm going to talk about fistulotomy, and I think Dr. Canters will talk about perhaps what I facetiously call the Takeda procedure, curettage and close. This has a 50% success rate, but safe. Should talk about flaps and others. So this is an example of a patient where we put all the drains and cetons in. Then we take them for the second stage, and where we're able to remove some of the drains and cetons. And then the third one, we're confirming that there's just one single tract left. And this particular patient then was able to have a low transuranic fistulotomy at the 5th or 6th exam under anesthesia. The prerequisites I've kind of alluded to already for this. Fistulotomy is not that common in Crohn's, but you can do it if they have proven that they can heal the other tracts and openings from unoptimized therapy, that they don't have chronic diarrhea. You can obviously rationalize it to a single tract. There's minimal sphincter involvement, and you have conformed consent with them and discuss the risk of minor incontinence alterations. Fistulotomy is not the case for most patients with Crohn's, absolutely not. You just can't do it. I'm going to skip over this. I think Dr. Canters will probably talk more about endorectal advancement flaps. So what about, the next classification, which is class 2C or 1 and C2. And in class 2C1, we're really looking at early, rapidly destructive and progressive perianal Crohn's disease, while class 2C2 is gradually debilitating. That still, both of these are ultimately, going to require a defunctioning ileostomy to improve their patient's quality of life. And we're typically talking about endeavor and loop ileostomy, with the corollary being that a good ileostomy is better than a bad colon, rectum, anus, or even a bad pouch. Now, this may allow the sepsis to settle and facilitate repair, but it's very well shown in several meta-analyses that 80% of the time when a quote-unquote temporary loop ileostomy is brought up, the patient is diverted permanently. Now, this is an example of a class 2C patient that had actually a scrotal abscess. And you can see we had to put about 6 or 7 cetons, and this poor patient required an orchiectomy. And that's severe enough. Now you're risking life and limb kind of situation. We diverted the patient. And then once you divert the patient, things really settle down, and you can be a little bit more liberal about taking out the cetons and drains until you're left with that single fistula. But again, keeping in mind that when we pull up a loop, most of the time it's going to wind up being permanent, and patients need to know that. Now, sometimes that doesn't work, and we move on to class C, which is really when you have an exhausted perineum and the patient is miserable despite diversion, and they really need to have their rectum taken out. And this is patients that we do an intracenteric proctectomy on, and patients call it Barbie butt. We all refer to it that way. It simplifies the conversation. Everybody knows what we're talking about right away, the flat bottom. And, the Barbie butt operation really can help patients improve their quality of life quite a bit. They can be miserable beforehand and have a lot of symptoms, if not all their symptoms, relieved once they recover from the proctectomy. Now, this is important because overall, about 20% of patients with perianal Crohn's disease will require a proctectomy. So it's relatively uncommon. Next couple of minutes, I'm going to talk to you about how to prevent the next class, which is class 4, because we do know that at 1 year after an intracenteric proctectomy, only 70% of patients are going to be healed. So the question for the next couple of slides is how to prevent a wet bottom, because that's why we operated in the first place. We removed the rectum. The first thing that this is a recent switch, and it's pretty easy, is that I do these horizontal mattress sutures with the knots tied on the side, as that arrow shows, because the traditional way that I was trained, and probably most people do it, is a figure of 8, and you can see the suture crossing the midline over the muscle, and that's where the tension is, and it probably leads to muscle necrosis. It probably is why we get a lot of wound dehiscences down there. So I've switched full on to horizontal mattress sutures. It seems to be helping. The other thing that I do is I'm very liberal with making gastroepiploic pedicled omental flap, where we take the one of the 2 gastroepiploics, and then we can pass the omentum all the way down and fill the pelvis, like shown in that CAT scan in the patient who had a pouch excision. Now, the other thing is that I learned from our Rob Hompes is that to use ICG on these omental flaps, because even with the naked eye, some of these flaps have areas of hyperperfusion, and dead flaps don't fill the dead space. And then finally, I'm doing a lot of prophylactic perineal wound vacs for about a week, either the peel in place, which is kind of the new kid on the block shown on the left, but then the patient has to sit on the flange, although it's only for 1 week, or the incisional wound vac with the flange off on the side via umbilical cord. And I think hopefully a combination of all these things can help us drive that 70% healing rate up. Now, unfortunately, some of the patients don't heal, and this is called class 4, and this is one of the real, I would say, breakthroughs of the top class classification, is recognizing this is part of Crohn's disease. Like we said, only 70% are healed at 1 year, and there's lots of things. Then we may have to go back to a wound vac to get it to heal. And how do we fix this? we throw everything at them. The goal of the proctectomy is to give them a dry bottom, and that's still the goal, even if we've already taken the rectum out. I don't think we have time to go through all the points that I put there, but you can see it's a multimodal combined medical surgical approach, sometimes getting plastic surgery involved, and definitely making sure their medical therapy is optimized. In the next couple of slides, I want to talk about the PISA 1 and 2 studies because it relates to the second task that I had, was to discuss the healing in perianal Crohn's disease. And this is the PISA 1 study. And basically, the study compared ceton drainage to ceton plus TNF versus those plus surgical repair. And basically, the trial was stopped prematurely due to futility because the ceton drainage had a 74% reintervention rate if you only put a ceton and stop there, while the surgical closure group had a 23% intervention rate. So this was kind of a little bit of a breakthrough, very hard to do study, and they did a great job. They followed it up with the PISA 2 study, and this compared just TNF for a year versus TNF for 3 months short-term plus fistula closure. And the MRI healing was more common after short-term TNF plus repair. And so the bottom line is that if the patient's Crohn's disease fistula is amenable to surgical closure, they should be offered a TNF and subsequent repair. And that brings us to the MRI. So, we use MRIs selectively yet liberally. We use it for complex fistulas, for recurrent fistulas, for fistulas that are not responding to initial ceton drainage because they have an undrained tract or branch or abscess that we didn't find until proven otherwise by MRI before the repeat EUA. And then finally, we do them before and after any repair because I do not trust Crohn's disease, and we need a good imaging. We have modern imaging to really help us, and that gives us the real definition of fistulizing perianal Crohn's disease healing in 2026 is if it's not healed on MRI, it's not healed and it's going to come back. The take-home points: fistulizing perianal Crohn's disease is common. It affects about 25% of patients overall. Treatment is all about patients' quality of life, giving them a dry, pain-free bottom. We always do combined medical surgical therapy, sepsis control, inflammation control, repair if you can. Goal is MRI healing. Divert if needed, resect if you must. Non-healing perineal wound prevention with optimization medical therapy, ICG augmented omentoplasty, prophylactic wound vac, and then when it does occur, early aggressive multimodal treatment. And then finally, I'll just say that randomized trials in this area by people such as our sponsors are sorely needed for combined medical surgical approaches. But the most important thing is that the team approach is really the key to success. And these are some of my buddies in IBD gastroenterology who we were able to see this you two at the Sphere a couple years ago. Thank you so much.
Thanks, Stefan, for a fantastic talk, whirlwind, and pretty much kept to your 10 minutes, so congrats. I also enjoy the fact that the non-surgeon here is the one wearing scrubs and the surgeons are wearing suits and ties, so I feel out of place. And with that, I want to introduce my colleague in our IBD section, Dr. Jessica Philpott, who's a really fantastic clinician and educator, and she's going to talk to us about medical therapies beyond anti-TNF, because now we have many drug classes available for Crohn's disease, and the question is, where do those fit in the treatment of perianal Crohn's? So with that, I'll turn it over to Dr. Philpott.
Well, thank you very much. I appreciate it, Ben. And if I learn anything tonight, it's don't trust Crohn's, right? Important words to live by. So today, in 10 brief minutes, I'm going to talk about management of perianal Crohn's disease, medical therapy beyond anti-TNF. And my goals for this 10 minutes are to review what are our goals for medical therapy, assess what current data we have for available advanced therapies, and look forward to how we can best address perianal disease and medically in patients who are experienced with TNF. Here's my disclosure and abbreviations. And basically, I'm going to be talking about a number of different studies, and they use a variety of ways to assess how effective these therapies are. And so I just want to kind of define those briefly, although frankly, by study, they'll vary as well. But basically, we consider clinical activity the presence of one or more draining tracts upon gentle pressure, clinical remission, or sometimes called in some studies healing, using the CPF fistula drainage assessment index is no drainage through the fistula on gentle pressure. A clinical response is reduction from baseline of 50% or more in the number of draining tracts. And some of the studies get more aggressive, and as Stefan was alluding to, and look at radiologic remission, and that's defined by pelvic MRI as absence of activity in perianal fistulous tracts and the absence of local complications such as fluid accumulations. And then combined remission, which a few good studies looked at, would be combined as clinical closure of all the external openings along with MRI findings. Some of the studies do look at unscheduled surgical approach, which would occur when a patient had a complication requiring urgent surgical care. And some of the studies actually look at persistence of medical therapy as a proxy or surrogate for actual efficacy. And so the assumption is that if a patient is staying on that medicine, that means it's working well enough for their fistulous disease that they're not needing to change. And then finally, relapse rate is what we would expect it to be. So when we say beyond TNF, we kind of have to say, what do we mean by beyond TNF? And so obviously infliximab is considered the gold standard for medical therapy of fistula still in 2026. And one of the first studies was actually all the way back in 1999 when one of the grandfathers of IBD care, did actually a placebo-controlled trial, which are kind of hard to find for fistulous disease. And they showed immediately an overall response rate to infliximab of 62% compared to 26% in placebo. And then with eventually 46 complete response versus 13. So that's pretty good. Some years later in 2004, the endurance trial was another randomized trial, which again, that it's nice to have these. And it did show that by 1 year, patients that showed an initial response to infliximab, 36% of those had remission compared to 19% on placebo. We have less data for adalimumab and certolizumab. There's some signal and it can be used. Certolizumab, we just really don't have very good studies, but it's not something we use commonly. And keeping in mind with TNF when we're treating that levels do matter. So usually for infliximab, we're looking for 12, at least 12, but usually 15 or higher for closure. I'm not today going to talk about antibiotics, immunosuppressants, injections, or hyperbaric oxygen, but these things are used. So let's dive in and talk about ustekinumab to start off with. And when we talk about the data, it kind of shows what the limits are to our understanding. And so we have meta-analysis looking at this, and really this data is derived from post-hoc assessment of clinical trials looking just at ustekinumab for Crohn's, and then retrospective cohort studies. And in general, it's measured about 41% response rate and 17% remission on this therapy. So these numbers really don't look that good. Looking at bio-naive patients in real world, we do see in the GetAid study, which was done in Europe, probably a little bit higher rates. So 16%, 64. So at 2 years of therapy, 64% remained on the drug, suggesting they're having some response, and only 22% required surgery. So that's looking a little bit better. And there's some debate, but levels probably matter when you're using ustekinumab to heal your fistulas. Then looking at vedolizumab, again, we don't have a lot of great data, but just post-hoc analysis and cohort meta-analysis will show us about 30% closure rate. And there's some neat, there was actually a pretty neat study done by Dave Schwartz some years ago looking at use of vedolizumab for fistula healing. And what they didn't, this is not placebo controlled, but they used 2 different dosing regimens. And it's kind of, you see there's a really pretty rapid uptick in that first line. So the response rate initially was pretty rapid. And then over time, you see a pretty good, endurance of this therapy. And if you look over there, they had actually up to 50% at week 30 had 100% fistula closure. So they are seeing pretty good responses there. But I think it just kind of gives you some idea of the timing of it. With these 2 agents, there seems to be a pretty high relapse rate. And so looking at a cohort study of both ustekinumab and vedolizumab, they found that up to 54% would go into remission, but for ustekinumab, we'll have about 11% a year relapse. Vedolizumab, almost 50% remission, but again, many of them were relapsing every year. So since we don't have, those numbers aren't very impressive, we're really looking for other agents. And the JAK inhibitors have certainly attracted a lot of attention. We know that variations in the JAK-STAT pathway have been associated with perianal disease, distal disease, and abscess. So this pathway looks like it should work well. And we have actually a really nice placebo-controlled trial looking at selective JAK for healing fistula. Unfortunately, it's of filgotinib, which is not approved in the United States and probably won't be, but anyway, just kind of as a proof of concept. And so this is showing the response rates. And then at the time point at 24 weeks, we have like a 47% healing rate in the patient. So that's, showing a good response. For upadacitinib, which is the JAK inhibitor that we are using for Crohn's nowadays, a nice study was recently published looking at post-hoc analysis of phase 3 Crohn's trials. And noting these are very high-risk patients. Most had failed 2+ therapies. Over 3/4 have been exposed to TNF. And 14% of them had fistulas disease, although of those, only a portion had draining fistulas, and those were the only ones they actually looked at. But they did show at week 12 a high percentage showing resolution of drainage at week 12, and actually closure in 22%. And then this endured, so out at 52 weeks, seeing 20% resolution of drainage, and the close to 20% for external closures. Now, the authors, I think this is the study is interesting. I think the numbers were not quite what people are hoping to see. And the authors even admit that these numbers are not dramatically different from post-hoc analysis of ustekinumab that was done 10 years prior. But they do note that these were extremely like patients of high risk, very medically refractory disease. So it's probably a different patient cohort. And one of the things I really liked that they did, because as I was writing this talk, I started thinking about it's our assumption that if we can achieve mucosal healing, we're likely to achieve fistula healing. And so they actually looked at the patients and they tried to see what was the overlap between patients that achieved resolution of drainage and what was and the patients that achieved rectal healing. And in fact, while there are a good number of patients that achieve both of these, it's not a one-to-one concordance. So some patients had closure of their fistulas without rectal healing. Some had rectal healing without closure of the fistulas. But if they had neither of those things, that obviously was not that they were not succeeding. So I'm going to move on to talk about selective IL-23 inhibitors, and really we're lacking much data. We have one study that's looking at post-hoc analysis in Asian countries, and they showed resolution at 12 weeks for 28% of patients and 57% at maintenance, so 54 weeks. Stay tuned because there is actually a trial of guselkumab that's specifically looking at treatment of perianal Crohn's, the Fusion trial. So I think we're looking for that data, and we're hopeful that this will suggest some efficacy from these drugs, but we just don't have that yet. So let's talk about dual therapy. With Crohn's disease, as monotherapy has not been fully therapeutic, and we have this therapeutic ceiling, there have been a case series looking at dual therapy, and it does show a decent closure rate of about 48%. When I was writing this talk, I wanted to make a nice big table for you and show you what percentage for each drug of closure. But I came to the conclusion after reviewing all these studies, you really can't compare these studies very well. It's really apples to oranges. And so when we look at percentage rates, there's a lot of variation in how that's collected. But my key takeaways for you are that medication-induced closure of perianal fistula disease is difficult to achieve, but it's a very important part of management. Our studies are lacking. And in 2026, the recommendation is you need to choose a therapy that's most likely to treat the patient's overall Crohn's disease. So our newer agents are demonstrating higher efficacy in patients that are TNF exposed. So we're likely going to be going to those more often than the older drugs. If a patient experiences mucosal healing, but they have progression of your fistulas, that you're going to have to address it on a case-by-case management and how you manage it, because that is a tricky situation. So with that, thank you for listening.
Thank you very much, Jessica. This was a brilliant summary on the medical treatment of perianal Crohn's disease. Also want to emphasize that you can post some questions in the chat. There will be a Q&A after the next presentation, so we will definitely ask some questions to our panel. And now I'll like to go over to the next talk, which is going to be given by Dr. Eric Canters. Dr. Eric Canters is one of our colorectal surgeons here at Cleveland Clinic. She's the Associate Program Director for the Colorectal Fellowship, and she's really an expert in dealing with these perianal fistulas, and I'm very eager to see what she has to say about it.
All right, thank you very much. I am hoping this is... does it look like I'm sharing a screen?
Yes, you are.
Perfect, excellent. All right, so in keeping with the theme of the evening, I'm going to point out two really important things. First of all, there is no such thing as a straightforward fistula, and that's a general statement across the board. And more importantly, there is no such thing as a straightforward Crohn's patient. So to quote both Drs. Philpott and Hullabar, you just can't trust the patients. Unfortunately, we want to trust what they're telling us, but their disease process tends to play by its own rules. So fistulizing perianal Crohn's affects about 1/4 of Crohn's patients, and another 10% will have other perianal manifestations, fissures, stenoses, skin tags. And unfortunately, this perianal disease, particularly the fistulizing form, is one of the most severe phenotypes and can present before or after luminal disease, and even in rare circumstances, independent of. We know that it's associated with higher hospitalizations, surgeries, medication requirements, and unfortunately, fecal incontinence. So when I'm meeting a patient for the first time, and I'll be honest, I'm gonna talk a lot less about the data and more about setting realistic expectations and how I think about patients with fistulizing Crohn's disease. When I think about the patients for the first time, I have 4 main things I'm thinking about. 1, working on eliminating their sepsis, recognizing that until I have their actual infectious process under control, the likelihood of us being able to have effective medical management is going to be very low. Then I think about, once we get them under control from an infection standpoint, once we get them under control from, hopefully, from an inflammatory standpoint, how am I going to close their tract? In doing so, I'm also thinking about how can I preserve their continence and their sphincter function, and then what in the long run can I do to minimize their recurrence? Within that Crohn's population, there are many circumstances where a patient will be coming to me for the first time, not even carrying a diagnosis of Crohn's disease. So if I have a suspicion that this patient doesn't have cryptoglandular disease or some sort of traumatic or otherwise fistula, and I believe IBD may be playing a role, I will work to establish care with my very skilled medical providers, GI medical providers, as they will actually be the ones to really get this patient the highest chance of success with fistula closure. Importantly, I also really work on setting realistic expectations and explaining to the patient that this is going to be a long time. I am actually not the most important person right now. Your most important person is your GI. And over the long run, that's control, then we can start talking about getting your fistula closed. Very briefly, when I'm thinking about these fistulas, I'm trying to think about where they are in the context of the rectum, the anus, and the pelvic floor. High up fistulas are going to require very different management than down low fistulas. And for the purposes of these repairs the repairs I'll be speaking about, I'm speaking more about those in the perianal and the deep postanal space. We'll oftentimes also talk a lot about part classification, less because I think it's important for the patient, but much more important so that we can really track the progression of the disease. So thinking about the context, or the fistula in the context of its relationship to the sphincters and the pelvic floor. Is it going through the internal? Is it going through the external transsphincteric? Is it going above the sphincter complex? Because again, all of these will play a very important role in considering what are my options that will both give the patient success and closure, but also not leave them with chronic incontinence. So importantly, again, this is a combination of medical and surgical approach when we're trying to have success with Crohn's perianal fistulizing disease. And I must make sure the sepsis is drained and controlled prior to starting medical therapy. That requires oftentimes an incision and drainage. And in the interest of maintaining control, ceton placement. It's important to be aggressive early on so that you do not have progression of the infectious process, which could in turn increase chance of incontinence in the long run, or risk stricturing and need for permanent diversion. We already went through the classification, so I won't belabor that, but I find this to be an incredibly helpful tool to present to patients early on to explain that in reality, repair does not always mean eliminating the fistula tract. There are circumstances where repair may actually require something like a proctectomy, particularly in the Crohn's setting. So within the workup, the early workup, recognizing the tract, but also what the sphincter function is before even pursuing any intervention is really important. If a patient will tolerate it, I really emphasize doing an exam in office and getting an appreciation for the length of sphincter complex. Can I assess for an internal opening just on digital rectal exam? And how good is their control at their baseline? Because once they're asleep, the sphincter complex feels a heck of a lot shorter, and it's a lot harder to understand exactly what how much of the sphincter complex may be involved in this fistula tract. Imaging, early imaging to assess for abscess or collection, I'll oftentimes obtain CT scans. If I'm more curious about complex tracts, I'll involve MRI, and endoanal ultrasound has really fallen out of favor, but I will use it in some circumstances if I'm concerned there's an underlying sphincter defect. As Dr. Halabar mentioned, there's a broad spectrum of disease. And when the patient comes to you for the first time, we already start to kind of think through our head, what can I do to possibly make you better? The person on the left is the dream. That's the circumstance where like, okay, I've got a real good chance I'm going to get you under control. The one in the middle is like, okay, I've got a lot of work ahead of me, but if we can simplify your disease down to 1 or 2 tracts, then I can get these closed. And the third one is where you really start talking early on about, is stoma going to play a role in your care? And is stoma going to be our definitive management in the end? So I'm working on controlling the sepsis. I perform incision and drainage, ceton placement, and in circumstances where I can't find the internal opening because of inflammation, I'll oftentimes place a mushroom or a Malacot drain to ensure that I have good control of the disease. Secondarily, I'll repeat my exams. So doing an assessment in clinic is essential, but also the exam under anesthesia. At that time, I'll oftentimes perform flexible sigmoidoscopy, even colonoscopy, if I have any concern for what is the progression of inflammation or improvement on inflammation with their medical management. And fortunately, I'm spoiled. I have amazing gastroenterology colleagues who will also oftentimes join me in the operating room so that we can engage in shared decision-making amongst ourselves and then later with the patient. And then in terms of definitive management, for some patients, that might be ceton placement. And that's a lot about assessing what their goals are and what is going to give them the best quality of life in the long run. Cutting ceton, this is not a traditional cutting ceton. It is something I will use to try to move a fistula down lower into the anal canal if their entire disease is under control, meaning that they are in clinical remission. And at this point, I'm almost dealing more with a traditional fistula than a Crohn's fistula. Similarly, fistulotomy is something that we will rarely use in the Crohn's patient population, but can do in circumstances of minimal muscle involvement and overall good control of disease. And then things like the lift procedure, the ligation of the intersphincteric tract, endorectal advancement flaps. I will talk about stem cells just briefly at the end. These are both sphincter preserving options. And then importantly, also thinking about things like diversion and proctectomy. Within those adjuncts, the medical management, this isn't just an adjunct, this is the essential management, but we can also consider fecal diversion. The data isn't great on how well that improves your chances of success, but what I'll often explain to patients is that when it comes to curing a fistula, if I'm concerned that the disease is too significant to pursue any definitive management, a stoma may help us get to the point that we can attempt surgical fistula closure. I'm not going to go into this too much, but for the ceton, this can be definitive management, and there can be consideration for removal after medication initiation. I saw there was a question, so we'll talk more about that. And as a cutting ceton, I don't use silks. I use actually a tight silastic band and allow for a passive fistulotomy in hopes that it will not result in any incontinence. In terms of the fistulotomy, this is one that we see to have the highest rate of success because we are not trying to close a fistula, we're actually opening it. But there is about a 5 to 15% chance of recurrence within the Crohn's population. And again, this is used only in patients where we feel they have good sphincter complex overall and minimal involvement in the fistula tract. Involves incising over the overlying tissue down to the level of the tract, most circumstances performing marsupialization to minimize the chance of tract reforming. The lift procedure, and so between the lift and the endorectal advancement flap, I would argue these are oftentimes our two primary tools that we have for surgical closure of a fistula tract. And I'll tell my patients, listen, if there's 100 ways to fix a disease, then you know there's no great ways to fix a disease. And so the great way or the best option for you is the one that your surgeon has the most success with. The lift procedure is not my preferred approach. The endorectal advancement flap is. But for some, the lift is the preferred treatment option. There's about a 65% rate of healing within the Crohn's disease, Crohn's population. And in this circumstance, it involves isolating the tract itself, and then, as the name suggests, performing a ligation and a transection, thereby essentially converting this transsphincteric fistula into just an it just involves the internal opening at that point. And this alone can resolve the fistula. My preferred approach is a mucosal or an endorectal advancement flap. The nuances between the mucosal and endorectal flap have to do with where it falls within the anal canal. Again, in this situation, approaching this, feel that the inflammation is maximally under control, and until I've simplified my tracts to the shortest and fewest number. Again, we involve curetting the fistula tract itself. I will close the internal opening, and in the process of doing so, in order to do so, I'll actually essentially patch. I'll close the muscle defect or the sphincter defect, and then patch over using a full thickness endorectal or endoanal advancement flap. I do like to curette out my tract overall, and I will oftentimes leave the external defect open to allow for continued drainage and minimize the chance of back pressure on my flap repair. With fecal diversion, I am very transparent with patients up front. So I will oftentimes quote this paper that explains that for those who attempt fecal diversion or utilize fecal diversion in an attempt to improve their fistulizing disease, only 34%, so about a third of patients in the end, will even attempt restoration of continuity. So 2/3 of these patients will have their stoma long term. And then within those patients, only 63% will actually have successful restoration. So that means less than about 1 in 5 patients will ever successfully really be reversed. There are certainly, this is a systematic analysis, and so you have to recognize that a lot of this data comes from a time when we didn't have as many medication options. And so I take all of that with a grain of salt, but I try to be, again, very realistic with my patients. And in this analysis, they found that use of biologics, which is now essentially standard of care, and the this does show an improved chance of restoration of continuity. But I try to be transparent and honest. Proctectomy may also be the end result. And this is where having those frank conversations early and upfront about goals for patient are really essential. And Dr. Hullabar did a beautiful job talking about the nuances. So stem cell therapy is a hard one to really touch on within the US, as this is not a readily available approach to management, but this can be done under certain circumstances with clinical trials and in the EU. So I will always encourage patients to pursue a stem cell therapy option if they're not yet ready to consider stoma when I think that's warranted, or when I feel that their long-term continence is limited. So the benefit here, it's again a sphincter preserving therapy. We are not cutting anything. And so I explain to patients there are no bridges burned in the attempt at stem cells. So the Takeda procedure that Dr. Hullabar mentioned is related to a curettage of the tract itself and an injection of mesenchymal stem cells. And there is a Takeda Pharmaceuticals actually has their own name brand version of stem cells that are injected into the tract, and the tract is then closed. And importantly, the largest phase 3 trial, the Admire Crohn's disease trial, showed that there was a combined remission rate of about 50 to 60% of patients across the board with use. And long-term success rates across the board look like about 50% at 12 months. And so if a patient has access or means of getting their hands on stem cells, I fully encourage them to try them, but also acknowledge that Unfortunately, this is not readily available. For example, we do not provide stem cell therapy at Cleveland Clinic. And so I have limited opportunity to provide it for them. So in the end, when I think about these fistulizing Crohn's patients, it requires combination therapy. And I will credit my GI colleagues as really being the ones that do the heavy lifting. And I'm just kind of there to nip and tuck once things are better. I have to set realistic expectation for the patients. That's both in terms of number of procedures, how long it's going to take to get things closed, and what's the chance of stoma. My real job is to control the sepsis and give the meds the best chance of success. And for some, CTON may ultimately give them that best chance of success and can be considered definitive management. Until the inflammatory disease is controlled, they're significantly less likely to have success with surgical management. Thank you.
All right, so we had an action-packed presentation that really covered almost all the aspects of perianal disease. I think maybe the best thing to do at this point is we have some great cases prepared by some of our expert fellows, and we can get to any additional questions in the context of those cases. There's been a great chat. Keep putting your questions into the chat, and the panelists can also respond there. But I want to introduce now Dr. Sophie Trujillo, who is our fourth-year advanced IBD fellow, joining us from UC Irvine and with us for a year before she goes into practice in Florida. And Dr. Trujillo, maybe you can pull up your case and we can go from there.
Okay, great. Thank you. All right, so I'll go ahead and get started on the case. Steve, next slide, please. So this is a 30-year-old female. She has a history of Crohn's disease. She's not had any surgeries before. Her social history includes no tobacco, alcohol, or drug use. She has no family history of IBD or colon cancer. Next slide, please. So her IBD history started in 2021. At the age of 26, she had developed some diarrhea, rectal bleeding. She had a colonoscopy in May that showed inflammation from the rectum to the transverse colon. At that time, the path was consistent with chronic active colitis, and she was diagnosed with ulcerative colitis initially. She was treated with prednisone and a short course of 5-ASA, which she self-discontinued after a few months because she was feeling well. She had a repeat colonoscopy done in August that was reported as normal. From 2022 to 2024, she felt well. She was off of medication and wasn't really following consistently with a GI provider. However, in 2025, she started having diarrhea, rectal bleeding, perianal swelling. A colonoscopy was done that revealed pancolitis with a normal terminal ileum, and the path also again showed chronic active colitis. At that time, she was started on vedolizumab without significant clinical improvement. Next slide, please. And then about a month later, she was hospitalized at an outside hospital with a left labial abscess. She had an EUA done at this hospital that noted a 2 to 3 centimeter fistula at the proximal anterior left anal wall, tracking to the left labia majora abscess with no point of drainage at the skin noted. So the abscess was drained, and a 22 French Bezier catheter was put into the space to clear the infection. And at this point, her diagnosis was changed to Crohn's disease because of the perianal disease. She was continuing to have a lot of symptoms, diarrhea, as well as drainage and pain from the labial region. So at this point, vedolizumab was switched to infliximab with improvement in the diarrhea, but she continued to still have perianal drainage and discomfort. Next slide, please. So this is going to be our first stopping point. In summary, she's a 30-year-old female. She was initially diagnosed with ulcerative colitis in 2021, was initially treated with oral 5-ASA therapy with remission. And then in 2025, she had a relapse in the disease and developed a perianal abscess with a rectal vaginal fistula requiring IND and reclassification of her disease to Crohn's. She was initially treated with vedolizumab and then without much response, and then transitioned to infliximab.
Great. So Dr. Philpott, this patient comes to you in the office. What are going to be your first steps from here? And what do you think about the infliximab treatment?
So I certainly want to involve my colorectal colleagues, because if there's a constant and undrained infection, then until I have that resolved, it's hard to get that under control. So I do want to involve them. And then in regards to infliximab, just as we talked about in the review, certainly doses matter. So I want to know where I'm at, what my levels are. And certainly I'm going to push my levels to the mid-teens for someone that has perianal disease.
And what's your feeling about combination therapy with immunomodulator in the context of perianal disease?
So I feel strongly that unless there's an absolute contraindication, everyone that undergoes infliximab induction should be with concurrent azathioprine. If there's a contraindication, they can be on methotrexate. I think we have a lot of data to support that during the induction through at least 6 months. The data in terms of how that would impact perianal healing is not there necessarily. I mean, there's some studies showing azathioprine can help, but yeah, I think I would personally do that as dual therapy.
And then in terms of, so you're going to refer them to the colorectal surgeon. What about imaging? How do you utilize imaging in the workup of perianal disease? We heard Stefan's comments, but I'm curious what yours are.
Well, I like a good MR of the pelvis protocol, like, with contrast protocol to look at it. But I'm going to, of course, consult, because sometimes my surgeons want to start with EUA. And if they're going to proceed with that, it may not be necessary at that juncture. So, but if on my own, I would get an MR of the pelvis.
Great.
Can I ask Dr. Hollibar actually how he feels about an UC patients with a perianal fistula? Is it always a Crohn's disease patient, or are there any patients that you can still qualify as remaining ulcerative colitis patients?
You're muted, Dr. Hollibar.
Thank you. Sorry about that. Great question, Anthony. So I would say that my answer is ulcerative colitis patients are allowed to have cryptoglandular fistula. It's uncommon, but often, patients with ulcerative colitis have diarrhea and they can get what we call a low pressure fistula, fissure, right, which is a break in the anal canal, and then that can lead to what would be analogous to a cryptoglandular fistula. Now, that being said, I think, we may have to make the assumption that it's related to Crohn's disease because it's going to have much more implications about what we're going to ultimately do and what our goals are for that patient. And I think that, the cryptoglandular complicating ulcerative colitis is kind of a more nuanced thing. And we can also tell by how the fistula heals, like these Crohn's fistulas often will have very angry external openings, and cryptoglandular ones and ulcerative colitis cryptoglandular ones, often the external opening, it's kind of more, looks like a more, a straightforward, less complex fistula.
Okay.
So Dr. Cantors, this patient, so Dr. Philpott has sent this patient to you. What's going to be your next step in the evaluation?
Yeah, so I appreciate her caveat about maybe not ordering an MR until we see if we want to do an EUA. So I do like, if it looks, this is a first time, no evidence of complex multi-tracking disease externally. Like sometimes you look at a bottom and you see there's like 5 different areas where it's trying to fistulize out. In that situation, perhaps getting an MR will help guide an EUA. But in this circumstance, I would start with an EUA, especially if she had appropriate decompression of the abscess and it's not clear whether they drained into the labia. I'm assuming they made the IND in the labia itself. But I would perform an EUA, speak with Dr. Philpott, for example, if she wanted me to perform a colonoscopy with TI intubation, get a sense of kind of what her goals would be from an endoscopy assessment. And then I would hopefully put a ceton in. That's really going to be my goal, is just getting control of the infection so that whatever medication option, the infliximab basically has its best chance of success.
And considering those patients, assuming that this patient would come through emergency with an abscess, like how do you feel about having a CT scan done in emergency already? I mean, it happens often, but is it actually helpful?
So I'm sleeping with the enemy here. My husband is an ED doc, so I am actually a big proponent of the scans. The main reason I find that is that they're so easy to get, that at this point the radiation dose is so low that I will take what extra information you can give me. The MR, the harder thing about the MR is the difficulty in obtaining one, how long it takes for the patient, claustrophobia, et cetera. Like there's a lot of other factors that play a role in the MR. At least if I have a CT scan already in front of me, I'm not going to complain because I can be sure that I'm getting complete control of the abscess, as opposed to discovering after the fact that it actually was like a deep horseshoe, like a deep postanal space infection. I thought it was a lateral abscess all along. I won't say no to extra information if I don't have to ask for it.
Perfect. So, Dr. Trio, what happens next?
Okay. Steve's pulling up the slides. All right, so about a month or two later, she presented to the Cleveland Clinic emergency room with her symptoms. She ultimately underwent an EUA, which showed an anterior anal fistula communicating to the left labia. The EUA procedure, she had a fistula probe inserted to the fistula, and a ceton was placed at the anal vaginal fistula. Then a counter incision was made above the great labia cavity, and another ceton was placed between the cavity and the abdominal fistula opening. Flex sig was done at that time that showed normal sigmoid colon, and then she had mild proctitis with no ulcerations. Next slide, please. We got some recent blood work. In December, CBC was normal. Her nutritional labs, iron studies, B12 and vitamin D were also normal. CMP was normal. CRP was also normal. And then her infliximab level was 12 with no anti-drug antibodies. And this is on monotherapy at a standard dose of 5 mg per kg. Next slide, please. And then this is an EUA, MRE that was MR perineum that was done after the EUA. And this was done in November. Steve, if you could press play on the video, but essentially you'll see the fistula kind of going anteriorly. There's a kind of a smaller tract, more midline, and then you kind of see the larger cavitary fistula on the left labia. Okay. Next slide, please. And then this is our final stopping point.
So, Dr. Philpott, I'll go to you first. So now you've got a little more information about the infliximab. How would you adjust dosing at this point, if any, and sort of what are your goals in terms of therapy?
So a level of 12, I mean, that's a pretty good level. You could still push it a little bit to try and get up to 15 or above. You're a little bit past when you'd be using dual, but you know, discussion of using azathioprine or not. It's hard to say how much of this. I mean, we don't have control of the situation, I would say, but it looks like mucosally things look pretty good. So I think to some extent, sometimes you have to keep trucking along for a while to just try and in terms of resolving the inflammatory burden on our side, keep going. So I wouldn't change therapy at this point. Certainly I might, but I would certainly keep dose optimizing.
I know your talk was beyond TNF. I think we're all very scared to abandon infliximab when we're using it, especially for perianal disease. So what does it take for you to say, you know what, I need to try something else? And you showed data for all the different classes, but what's your go-to for when you go beyond TNF?
Okay, so I think when it gets tricky is if I have full mucosal healing, but my perianal disease is progressing. And so I'm a little bit concerned I'm going to jeopardize my control of the mucosa when I transfer. But certainly if they're on kind of a lower level treatment, they're maxed out on the dose, and I'm just like sprouting fistulas everywhere, I need to change. And so certainly at this, I am looking a good bit at like the JAK inhibitors, right? So if I feel that I have failed TNF, then going to JAK in general, and that's what in managing Crohn's, that's a go-to. A selective 23 also would be high on the list, depending on the patient. So those are my thoughts. And then there's some roles where you might think about a little bit of a dual therapy if you just, like if you're on your third therapy and there's a first thing that worked for the mucosa, can I add something to hit the fistula?
Great.
So I
And so
want to
the
ask a question. Sorry, I just want to ask Dr. Hollerbar, like when you see this case, and I know you haven't seen the patient, but how would you classify this patient in the top class classification? But also through this question, actually, I want to know from you, how do you use this top class classification in your clinic? And do you find it's helpful, or do you bring it up with patients? I'd like to have your experience with from your experience with this classification.
Yeah, thanks, Anthony. I do think the top class classification is clinically helpful, right? So this patient would be, it sounds like a class 2C2, meaning they have kind of, or they may be heading towards being a class 2C2, where they're having kind of slowly debilitating and destructive fistula. And I think that, like I mentioned earlier, I think the biggest thing that I found the top class is helpful for is that it recognizes that diversion and proctectomy are valid treatments, right? So it hasn't popularized them, but it's kind of brought it more forward in the discussion with patients that this may be something that certainly we are as physicians are thinking about. And so I think that allows us to have earlier conversations with the patients. One of the most interesting things I think in the research that's come out on the top class so far is the idea of downstaging patients' classes. And that's also really helpful that, let's say they have a class 2C2 heading towards an ileostomy, but then you get them on more effective medical therapy and they kind of can go backwards. And, ultimately you might be able to get them to have no fistula at all, and then they're class 0. So I do think patients, go through to different stages, like in a Sankey diagram, and that's a very helpful way to think of it also.
So I guess before we wrap this case up, I mean, my question for the surgeons is, when would you attempt a repair for this patient? There was some of the discussion in the chat about sort of timing and goals, but based on what you've seen here, Dr. Cantors or Dr. Hollibar.
So the rectolabial and the rectoperineal or rectovaginal fistulas are my personal favorite. So for her, once Dr. Philpott feels that under good clinical remission based on her flex sig, based on her levels, etc., the first thing I would actually do is shorten her whole tract, because currently she basically has her entire perineal body involved, and it sounds like she's a secondary tract going towards the perineum separately. So simplifying the tract down to the level that it's essentially just sphincter complex, I would not attempt any repair until it was nothing more than sphincter complex. So I'm going to guess it'd be probably at least 2 to 3 EUAs once she's doing well before I even attempted a repair. So she's got a good 9 months before I get to try an endorectal advancement flap on her. And especially with these anterior fistulas in women, especially young women, I'm very, very particular about preserving sphincter complex, and then also discussing fistula depending on what if she has any persistent disease, evidence of any persistent disease.
Great, thank you so much. This was a great case. Thank you, Dr. Trujillo, to present this case. Let's move on to the next case. The next case is going to be presented by Dr. Christopher Preen, who is one of our colorectal fellows here at Cleveland Clinic. Christopher, why don't you start?
Yes, thank you so much. Hoping to build on the discussion that's already started. Steve, next slide. So the second case is a 32-year-old female presenting with anal pain, which has worsened over the past 3 to 4 weeks. She's been having upwards of 8 to 10 bowel movements a day. Her pain is worse with defecation, and she's been avoiding food as a means to decrease the frequency of her bowel movements. You ask her if she has any blood, and she denies that. Interestingly, she is 6 weeks postpartum. She did deliver via C-section. When you examine her, it's very difficult to examine her. She has a lot of discomfort. It's a very tough area to see. From what you can kind of gather on the outside, it looks like there might be some sort of a chronic posterior midline fissure, and there may or may not be a midline external fistula opening, but very difficult to determine on exam. Next slide, please. Delving into her history a little bit more, she does have a history of Crohn's disease. She had a prior ileocolic resection. She's gone through several medications for her Crohn's disease, as you can see here, currently on Stelara, but previously had been on infliximab, 6-MP, mesalamine, budesonide, prednisone. She is an active smoker, and she doesn't have any family history of IBD or colon cancer. Next slide, please. So at this point, because you're having such difficulty examining her in the office, you discuss with her about going to the operating room to get a better look, and she's agreeable. During your examination, you notice and you appreciate several perianal skin tags. And in the canal, she's significantly inflamed. There is a posterior midline fissure that appears chronic in nature. The edges are very rolled. And there's also what appears to be a midline fistula. And when you palpate this area, you get some expressible purulence. You're not really able to determine how much muscle is involved at this point due to how inflamed the area is. However, at this time, the safest approach is taken, and you decide to place a ceton. You perform chemodenervation of the internal sphincter muscle, hoping to help with the fissure, and then also I like to perform some Kenalog injection into the canal to help with the inflammation. Next slide, please. So she recovers from this, and about 2 weeks later, she comes to your office for follow-up. She's reporting marked improvement with near complete resolution of her pain. She notes that she does have some discomfort and pruritus related to the ceton. She's continuing to have 8 to 10 loose bowel movements a day and remains on budesonide. She has not resumed her biologic therapy since her time in the operating room with you. You examine her, and she shows significant improvement in the anal canal inflammation. The posterior midline fissure is healing, not completely gone, and the posterior midline ceton is in place with scant, much improved expressible drainage. Her question is how long the ceton needs to remain in place and what her next option would be for definitively taking care of this fistula.
Great, thank you, Chris. Just for me to remember, I'm not sure I saw that, but is this patient on active medication for Crohn's disease or not?
Prior to arriving at the hospital, she had been on Stelara, but had been through several different medications throughout her history.
Okay, so why don't I ask Dr. Philpott first, do you keep her on Stelara or do you change based on the fact that she now developed like a perianal fistula?
So there's some details that I'm not aware of on this case. And so the question is what else she's been on. But I do have concern when she's progressed to fistulization on that therapy. So I certainly would look at that pretty closely and look at what other signs of that not working, if there's a way to optimize that, or, you know, and what has she been on before. But it gives me some concern I may need to change your therapy, yes.
Okay. And just as a side note here, Dr. Canters, like this patient is postpartum, I think a few weeks before it all developed. And so what is your approach for patients with Crohn's disease? And I know this patient didn't necessarily have any perianal Crohn's disease during pregnancy or even before pregnancy, but your general approach in patients being pregnant, let's say with known perianal Crohn's disease, what would you advise those patients in terms of delivery?
I have a really hard time with this one. Pouch patients, C-section, period. That is what it is. For patients with fistulas, I have a again, it's all about like, what are their goals? If they feel really strongly about a vaginal delivery and they have maybe perianal tags and perianal fissures, then I think that it's reasonable for them to consider it, recognizing again that like, hey, if they have a tear, this may affect them in the long run. Like, I'm almost more nervous about the injury from delivery than I am about their perianal Crohn's disease at the time of delivery. If I have ever done a fistula repair on them though, if they've already are post-repair, I am a lot more insistent on attempting avoiding any chance of further injury. And again, it's all about the sphincter complex and my fear of further injury or injury in anticipation of an eventual challenge. But I'm also a big proponent of allowing the patient to do what they feel is best for them. And so we just kind of have that conversation together.
Okay.
Except for J pouches, period.
Okay. And Dr. Olibar, there's a question in the chat about the use of Botox for Crohn's fissures. what do you think about this specific fissure in this case? And what do you think, how do you feel about doing Botox in Crohn's fissures?
Yeah, it's a good question. I mean, I agree that there's not really data to support it, but most likely what happened is that the patient had an anal canal ulceration related to Crohn's disease. That's one possibility. Or it could actually been a fissure. It sounds like the surgeon put the Botox in more for symptoms, not for fistula healing per se. And it sounds like between the Botox and the Canalog, that actually helped relieve her symptoms from the fissure. So I'm not opposed to it. I mean, the patient has chronic diarrhea. You do have to concern that might get a little bit of minor incontinence from it.
Mm-hmm. And how long do you keep the seton in this case? And what is what are the factors for you to decide to either remove the seton, try to do a surgical repair? What are you looking at?
Yeah, I think this came up. This question came up in the chat, but it also used to come up a lot, especially in the pre-PISA era. It was made a little bit harder to discuss because we didn't have good data. But now we have PISA 1 and actually also PISA 2. And PISA 2 didn't do chronic seton drainage alone. You know, the comparator was chronic seton drainage with TNF. I think if there's a hole in the anal canal, the internal opening, this is not going to heal without surgical therapy. So the real answer is, you know, trying to get to repair. This case is complicated by an anal canal stricture, and that often will completely obviate any kind of formal fistular repair. And it's unfortunately pretty common. So that doesn't bode well. But I will say that if you can kind of rationalize the situation, shorten the tract like Dr. Canters is talking about, and get the patient to have minimal symptoms and live with the fistula, then certainly I have a frequent strategy of waiting a year in these irreparable fistulas, letting the tract get completely epithelialized in both the internal and external opening, and then you can just remove it in the office and the patient can live with the fistula and the very low-grade symptoms that they have a small amount of mucus purulent drainage from the tract.
Mm-hmm. And just basically a very similar question to you, Dr. Canders. Like if the patient asks you, I want this fistula repaired, and assuming there is no anal stricture, like what do you look at for the timing of a surgical repair? And I understand you prefer the rectal advancement flap. And can you tell us if there's any specific reason why you prefer the rectal advancement flap? And what are you looking at to see what is the right timing for doing a repair?
So the biggest factor for me is the disease, is the underlying disease under control? That's the most important thing. So do I see any persistent rectal inflammation? Do I see pseudopolyposis in the distal anal canal? Do I see, like, what factors do I see? Are there skin tags? You know, when the skin tags are like bright and shiny, as opposed to when they become kind of soft and they look more like normal skin tags, not like Crohn's disease tags. So I'm looking for all those kind of factors to say, okay, this tissue's ready. Now, if the tract epithelialized, that's probably like the best indication that this fistula is ready for me to try to do anything I want to it. But it doesn't have to be. It's just a lovely point in the patient's favor if it's well epithelialized. I'm also trying to make sure there's not a ton of hypergranulation tissue coming out of it, because I feel like that is a sign that the back pressure is going to build up once I do my flap. And again, the other big thing is, so I do shortening of all my tracts. The time I'm willing to do the repair is once I've got it down to the level of just the sphincter complex. I do 2 to 3 months between each EUA in terms of making sure that everything that I did previously is well healed and not going to become a problem down the way. I feel like it also kind of gives the body a chance to manifest a new fistula if it needs to, so that I know that things aren't quite ready. And I also usually see them in office, and I'll do a little silver nitrate to any hypergranulation around that area to try to induce a little bit more scarring to set the body up for success. Can't remember if I missed one of your questions.
No, that's it. Let's move on with the slides. Chris, why don't you pull up your slides and we can move on.
Okay. So you talk with her and you are agreeable to reevaluate her in the operating room. So 8 weeks later, She's taken for evaluation. At that time, now the midline fissure is almost completely healed. The inflammation is significantly improved, nearly resolved. The midline fistula has, when you're able to evaluate, has very minimal sphincter muscle involvement. So at that time, you're comfortable proceeding with a fistulotomy, as we discussed earlier. And then once again, just to kind of get rid of the rest of the inflammation in the canal, Kenalog's injected into that area again. Next slide, please. So at follow-up after this procedure, she's feeling much better. Her fistulotomy site is healed. In the subsequent months, she follows up with her gastroenterologist, and she has transitioned to Skyrizi, and her perianal disease remains quiescent for several months. 7 months later, she presents to the emergency room with severe anal pain and feculent vaginal output. Examination demonstrates right labial erythema and fluctuance. She's taken to the operating room and found to have an abscess in the right labia, as well as an anal-vaginal fistula. An IND is performed at that time, and another CTON is placed. Over the next 6 months, she develops recurrent bouts of perianal and labial abscesses, requiring numerous examinations under anesthesia, INDs, and CTON placements. Next slide. So now she's back in the office again to discuss how she's doing. She reports feeling much worse. She's having considerable pain with bowel movements, especially when she wipes. She's having intermittent bloody drainage. She's got intractable pruritus from the area, and it's now impacting her in such a way that she can't even really sleep at night. Before seeing you, she was transitioned from again to Inflectra. She has had minimal improvement and is intermittently requiring corticosteroids. Next slide. So at this point, she's sent for an MRI of the perineum, and it demonstrates multiple intrasphincteric and transsphincteric fistula extending to the level of the perineal body. There's considerable amount of inflammation in the ischianal fat around the area, but no focal fluid collections or abscesses. At this time, the image on the right is a representative of what you see. There's several CTONs in place, numerous fistula. Next slide. So then the question is what to do moving forward at this point.
Yeah, we almost out of time, but I'll ask Dr. Hollebar, stoma or no stoma in this patient?
Absolutely. In fact, this patient will probably be asking for it. I think the important part about what kind of stoma you do, it's very easy to make a decision to make an ileostomy, but I noted that this patient had a previous, it said extended ileocolic resection. I presume that means a significant amount of small bowel was removed, and that makes sense of why the patient's having lots of diarrhea. So I would want to make sure they had an up-to-date an ileocolonoscopy so I can see the terminal ileum, and also anorography protocol, see the terminal ileum, make sure there's no Crohn's colitis. And if it really is just a little bit of the distal proctitis and perianal disease, then a colostomy might actually be in her best interest, because that won't make the diarrhea worse, right? So if you would go with the loop ileostomy, that actually may make the situation worse in terms of her high output.
And Dr. Ganis, when would you consider like a proctectomy in a patient like this?
Given how symptomatic she is, I think cool her down with a stoma for right now. Make sure that she's comfortable with that being her long-term goal. She's young. And then once everyone page and we feel that there's nothing further that can be done to optimize her, her chances of early healing with proctectomy will also be better if she's cooled things down. So probably a minimum of 6 months, but giving her a chance to make that decision. I wouldn't let her go more than 5 years, typically, with just diversion alone.
Okay, great. I think we're at the end of our time here. Dr. Cohen, you want to
Yep. So
did you have any additional question?
well, I mean, I think these are great discussions that highlight the role of multidisciplinary care, right? These are not straightforward cases, and they never are, I think, in practice. So it requires us working together and talking it through. And I think, as Dr. Canters had said in her presentation, really defining what the goals of therapy are for the individual patient, because it may be different for different people, and that's going to change our approach ultimately. So Really fantastic discussion. I want to thank everybody for joining tonight, and we want to encourage you also to join us for our other live from Cleveland Clinic programs, the next of which is going to be on February 18th on acute cholecystitis, timing tubes, and tough cases with Dr. Walsh. And welcome to 2026, everybody. We look forward to seeing you at all of our programs, which you can see on the screen here. So again, thanks to our panelists, Dr. Cantors, Dr. Hollibar, Dr. Philpott, and our case presenters, Dr. Trujillo and Dr. Preen. Good night, everybody.